So I'm called Gillian Slinger, and I am the technical specialist for obstetric fistula within UNFPA, and I'm also the coordinator of the global campaign to end fistula. Okay. I think one of the main reasons that Liberia was chosen was because it has a very high level of maternal deaths, maternal mortality ratio, one of the highest in the world, and yet huge potential because it's a fairly small country and a very engaged Ministry of Health, which is really fundamental. So a huge potential to have a big impact with the right resources coming into the country. And obviously, wherever you have a high level of maternal mortality, you equally have high numbers of newborn problems and equally high levels also of obstetric fistula cases within the context. I have a photograph actually with me that I took myself here. This was in a sub-Saharan country. It wasn't Liberia, and these girls here are 13 and 14. This little girl, Zaya, is 13 and Zikra is 14 years old. And they were both married, obviously very young. They had a very, very tough first labour, a very difficult delivery. They both had a stillborn child and they both suffered with an obstetric fistula. So that's an example where girls who've been married very young can have an obstetric fistula. But equally, any woman who doesn't have access to emergency obstetric care, notably a life-saving cesarean section, once they have a problem in obstructed labour, any woman can be at risk of having an obstetric fistula. And I've met women who, for example, have had 6 normal deliveries with no problem at all, and then for some reason they have a bigger baby or the baby's not in a favourable position on their next delivery, and they develop an obstetric fistula even after having many normal deliveries. Yeah. From my experience, what we find is that once women actually with an obstetric fistula, once they actually manage to get to a hospital, and for many of them it's really challenging even to know what the condition is and why they have it. But once they manage to get to the hospital and start to have help for their fistula, the fact that they find themselves with other women and girls with the same problem is already a huge therapy for them, that they can share their suffering, that they can share their story, and to know that they're not the only woman in the world with that condition, where they've been really stigmatized, they don't understand why it's happened, they're often rejected from their families. So kind of a key part of the process once they get to the hospital is this therapeutic counselling. That comes from within the women themselves, but obviously there are professionals there as well to explain that what they have is not because they did something wrong, it's not because they have been a bad woman or that they have got a serious disease, it's simply because there was a problem in the labour, and once they know that, they automatically accept the condition better, and knowing that there are many other women as well, that instantly helps them. And so the key entry point is kind of telling them about the condition, counselling them about it, and also preparing them for the surgery. Many of the women will never have left their remote, rural villages before. They've never been in a hospital before, and it's very, very intimidating, very frightening for them to think that they have to go through this surgery, and in a very kind of intimate area, and obviously very, very sensitive, very difficult for them to kind of go through that. And all of the counselling and the careful support leading up to that is really important. Also, many of them are in a very neglected condition when they actually reach the hospital. Many of them, sadly, in countries in Asia, in sub-Saharan Africa, for example, in Chad, they have serious problems of malnutrition due to being neglected from having a fistula and being kind of cast out from their society. And so they need really building up, not only the psychological build-up with the counselling and the support, but also their physical build-up. They're anemic often, so we need to give them iron and really get them in a good state of health, their nutrition, protein, and lots of vitamin in their diet, before we can even start to think about doing the fistula surgery. Once they are then in a reasonable state to undergo surgery, then we we provide the surgical care, which is done by an expert, trained, highly specialised fistula surgeon, because it is very, very difficult surgery. If we asked a medical doctor in the United States to provide an obstetric fistula surgery, because they no longer occur, thankfully, in the United States, they wouldn't have the necessary competencies to do it, because it's something that they don't have to address anymore. And we're very glad to have a number of very dedicated American fistula surgeons who've gone through really extensive training in the fistula affected countries with other experts to really build their skills up. A key part that we're working on very hard with the Campaign to End Fistula partners is the follow-up once they go home, and there are 3 components of that which are important. One is we want to know how they're recovering from their treatment. Are they still continent? Are they still well when they go home? The second part is, are they reintegrating successfully back into their communities? Are they accepted back? Are they able to pick up their life and continue and not have any problems? And then the third part, which is very challenging but very important, is about ensuring their well-being in any subsequent pregnancies once they've had a previous fistula repair. Because yes, we have been able to treat this woman, we've given her her dignity back, we've helped her to go back into her society, but many of the women will want to go on and have a family afterwards. So that follow-up is really, really important, to be able to make sure that yes, she's fine and she's going to not only live through her next pregnancy, she will not have another obstetric fistula and she will not have another stillborn child. So to ensure her well-being in her next pregnancy and delivery, but moreover to make sure that she survives it and she has a healthy baby. The women who present with a fistula when they're much older, they have a similar story to any woman or girl who's had fistula, apart from they of course didn't develop it at the age of 70 years. Many of them developed it in their adolescence, in their 20s. I met a lady in the Addis Ababa Fistula Hospital, and she told me her story. She was 70 years old and she had had a very complicated twin pregnancy when she was 20 years old. And both of the twins died during the very long delivery, and then from the age of 20 she had a fistula, and she said that her family abandoned her, her husband left her, and basically it was only when she got to the age of 70 that she understood what the problem was. But she lived for 50 years with the fistula, with all the being ostracized, the incontinence, not understanding what had happened to her. And when I talked to her and I said, can I take your photograph? Can I share your story? And she said, I want you to share my story with all my sisters across the world, because I don't want any woman or girl to suffer as I have. She said, my life is nearly over, but my life has been wasted. All my potential years of having a family, finding another husband, and being accepted as part of my community, she said, all of that has been lost. She said, now at the age of 70, I've had a treatment, it's been successful, I'm continent, for the first time in 50 years, and what I want to do now is share my message with women who are at risk of having fistula. And so the challenges of looking after women who are older are that they have had their fistula for a very, very long time, and many of them are elderly when they come, so you're kind of looking at their recovery from fistula, their reintegration as well after a lot of stigmatization, but also maybe looking at their elderly age issues as well. It really varies by context. It depends really in the context. I think in Liberia, if I remember correctly, I think about 30% or even 50% of the women have been abandoned by their husbands. So a very significant number have been abandoned. And it's really important to engage men, to share this information with men, and this is the broader advocacy work that's very important. We do that, like I mentioned, with the community health workers, but also we target and discuss with influential people, whether they are the community leaders or a refugee camp leader or some local figurehead, a religious leader, and they are very powerful vehicles to deliver the messages as well. And Yes, of course, men are absolutely fundamental in that targeting. And what we know is that with traditional birth practices as well, that men are often the decision makers about where a woman should deliver, if she'll be able to go to hospital. Men, but also older generations in the family, for example, the mother-in-law also has a key role, you know, to make about where a woman in the family should deliver, and if there's a difficulty or the labour doesn't appear to be kind of progressing normally, then what might be the next move. So it is really, really key that they're included in all these important messages.